תודה רבה על ההזמנה למשפחת ברזילי. עד היום רק הכרתי חצי מהמשפחה ברזילי, את החצי השני הכרתי הבוקר. זה הנושא שלי, ויש, בוא נגיד ככה, לא נולדתי בארץ, לא גדלתי בחיפה, לא הייתי סטודנט ברפואה, אבל כל שנה שהייתי בא לפה, אז אלי קרניאלי היה מזמין אותי לחיפה, לפגש, לתת הרצאה, ונפגשתי כל פעם עם אבא של ניר ומשפחה, עם דוד ברזילי, והיה נחמד גם לשוחח איתו על נושא של אנדוקרינולוגיה וגם אפילו לתת הרצאה. אני צריך להתנצל, אבל אני נשוי לבחורה ישראלית, אישה ישראלית, והיא התחילה ויכוח איתי מאתמול, ארוחת ערב, עד הבוקר שעזבתי את הבית בתל אביב, והיא אמרה לי, אתה חייב להרצות באנגלית. ואני רק עולה חדש 5 שנים, ואני מבין אותה, ואני מקווה שתסלחו לי אם אני אעבור לאנגלית, בגלל שהרבה יותר קל לי. אני הולך לדבר על השמנה, סכרת והקשר עם סרטן. And I'm going to talk about 3 aspects of the project. One is the epidemiology, מה הקשר בין כולם. אחר כך נדבר קצת על potential mechanisms, how we study in animal models and in human models, the connection. ואז אני אדבר על תרופות. And then I'm going to talk about the medications because a lot of our patients are receiving medications and there is a concern, as you'll see, as to maybe the medications are causing the problem. This is a study, as of many studies, on obesity and mortality from cancer. And what I've outlined here, both in women and men, are the various cancers, common cancers, all of which are associated with a higher mortality if you're obese. Mortality from the cancer itself. In other words, if you're obese and you develop cancer of these kinds, your mortality is higher for many reasons, one of which is the cancers are more aggressive and they don't respond to medications that they normally would. Question arises, if I'm obese and I have this higher mortality, what would happen if I took away the obesity? And there have been 3 international studies. This one is just one from Utah, where they took 10,000 patients who underwent bypass surgery to treat the obesity, make them thin again, and compare them to controls. And what they found is everything got better, but indeed even cancer mortality was reduced. So what you can see is that 15 compared to 5, you can reduce the mortality from cancer if you undergo, in this case, loss of weight because of bypass surgery. This leads back to the question that's come up from earlier talks about lifestyle, obesity, and a worse cancer outcome. What about diabetes? 100 years ago, Maynard was studying the connection between diabetes and schizophrenia. He didn't find it at the time, but what he found was a connection between diabetes and cancer. So not only obesity, but diabetes, both of these can increase your risk for cancer and death from cancer. And this just shows you schematically. If you look at the dark line, which is 1, this is unity. Anything to the right suggests that there's a worse cancer prognosis if you're a diabetic. And the only one, of course, is prostate cancer to the left. But all the cancers that we know about, there's an increased risk of developing cancer and increased mortality. This slide just shows you that there are many factors involved in this connection, many theoretical factors. Many of them are circulating, and I'll discuss them in a moment. Some of them are also local. In other words, the fat cell where the tumor is, where the cancer is, they are talking to each other. And this is called the tumor microenvironment. So we have the macroenvironment, that's obesity, diabetes. We have the microenvironment, what's happening right to the cancer cell itself. And as you saw from the title of my talk, there are two factors that we are concentrating on primarily. One of them is insulin, and one of them is cholesterol. When I talk about insulin, what I mean is that obese individuals, type 2 diabetics, have high insulin levels. They also have high cholesterol levels. And we believe that these two may be playing a role. Now, you can see how complicated patients with obesity and diabetes are. Very complicated. Many factors playing a role. It's very hard to then find the individual factors and actually test which ones are doing what in order to identify the factor and to look for therapeutic treatment options. But this just shows you, again, patients with diabetes, this line shows you where the diabetes starts. But years before the onset or diagnosis of diabetes, many patients have a high insulin level. So both obese and diabetic patients have this high insulin level. And a colleague of mine in Canada looked at breast cancer patients. They didn't have diabetes. They weren't necessarily obese, but she looked at their insulin levels in their bloodstream. And what she found is that a high insulin level, shown here, the higher levels, were associated with the worst prognosis, the worst outcome. So in patients who have breast cancer with a high insulin, they have a worse outcome. And this type of result led us to decide, how can we study this connection? Can we prove the connection? And can we show that insulin is not causing cancer, which is caused over here with initiation of the cancer? This is caused by oncogenes, mutations that can lead to the cancer. But could the insulin be driving progression, growth of the tumors, and spread to the various tissues? Because we know that it's the metastases that actually kill the patients. Insulin used to be thought only as an important metabolic hormone. It kept your blood sugar down, it put the sugar into the muscle and the fat cell, it made protein in the muscle so that you grew nicely, etc. So it was a metabolic hormone. We know today that insulin can drive cancer cells. And the reason we know that is because there are two receptors to which insulin can bind and stimulate. This one, B, on the right side, is the one that's found in the muscle, the fat, and drives metabolism. This one, A, is the one that drives growth and cancer cells. So we know that insulin, under certain circumstances, can actually drive cancer. So we built an animal that had diabetes in the male, and you can see this on the left-hand side, high blood sugar, high insulin, high fat in the diet, typical of what happens in our obese and diabetic individuals. The females, interestingly, only showed the high insulin. And you may ask, why were the females protected from this whole picture of diabetes, whereas the males were not? And it's very much like women who are young, who are protected, and when they undergo menopause, they are less protected. And we proved that by taking out their ovaries in these female mice, and they converted to become like the male mice. So instead of just having the insulin, they also had the high blood sugar and the high cholesterol. And we developed breast cancer in these mice, either by crossing them with transgenic mice or injecting breast cancer cells into the mammary gland. And what you can see here very simply is advanced growth of the breast cancer in these mice with high insulin compared to the normals. You can see here higher levels in these high insulin producing mice. You can also see at the bottom spread to the lung, much more in the mice who had the high insulin levels, suggesting that the data in the human patients we can show in the mice. High insulin levels, more aggressive tumors. And so we came up with the following hypothesis that the insulin, the hyperinsulinemia, the high insulin levels, driving that receptor I spoke about on the cell is driving tumor progression. And we can prove that by blocking the receptor, shown here, where the exaggerated growth of the cancer is brought down to the normal cancer growth by using something that blocks the receptor. So that's the high insulin level in the individuals. But I also said that the high cholesterol level and high triglyceride levels can also drive cancer. And that came out of epidemiology again, shown with some of these studies in this list, where they showed that triglycerides, total cholesterol, LDL cholesterol, a number of the bad cholesterol and triglyceride levels in the blood are also associated with a worse prognosis. Furthermore, there have been a number of studies that have come out in the literature that individuals taking statins, now we all use statins to bring down your cholesterol so that we can protect you from the cardiovascular disease, so Professor BR won't have any work on his patients. We try to protect the heart and the vessels by using statins. Well, it turns out that people using statins are protected from cancer death, strongly suggesting that high cholesterol levels can also drive cancer in our obese type 2 patients. So we did a similar study. We took mice, the ones that you heard briefly before, that have very high cholesterol levels, and we injected some human cancer cells into these mice, and exactly the same thing happened. Here you'll see in orange the aggressive growth of the breast cancer cells because of the high cholesterol in 2 different models. These animals have high LDL cholesterol, the bad cholesterol, high triglycerides, which you heard about earlier, and the low good cholesterol. So they are typical of what we see in our patients. And then if we just look at the spread of the lung, you'll see exactly the same thing. With a high cholesterol, you have more spread of the cancers to the lung. So I've shown you that epidemiological studies and statistics suggest the connection between insulin and cholesterol and excessive growth, and we have animal models that can help us prove the point, show us how it's actually happening, and we've now developed and found some particular cell membrane proteins that are potential targets, new targets for drugs for these very aggressive tumors. The third part of the talk comes up because a lot of people say, well, if my insulin and my cholesterol, particularly my insulin, is driving cancer, what happens if I inject insulin? What happens to all the diabetics who are taking insulin? And this led to concern that maybe the medications we are taking can perhaps make things worse. On the other hand, it's possible some of the medications can actually improve the situation. So this just shows you some of the drugs that we now use in treating diabetic patients, and I'm going to focus on 2, insulin and a drug called metformin. For those of you who are taking drugs, glucophage is the metformin in this country, the name of metformin. Again, epidemiology suggested that those who are taking insulin aren't as good a situation as those who are taking metformin. If you're on metformin, your survival rate is much better than if you're taking sulfonylurea or insulin. So let's look first at metformin, which I hope Dr. Barzilai is going to speak about because it's one of his favorite topics. And basically, This is the line of unity, shown here and here. And the suggestion is anything to the left is good for you, anything to the right is bad for you. And what you'll see is that in many of these studies, metformin is protective against cancer. People taking metformin have a certain protection against cancer. We showed, looking in patients with lung cancer, survival curves, and very simply put, these are individuals with not a metformin, these are individuals on metformin. Some were getting chemotherapy as well, some were not getting chemotherapy. But as the curve shifted to the right, in that direction, those on metformin had better early survival. So we were able to show in lung cancer patients the same idea, that taking metformin seemed to be protective for a while. Well, these and other studies spurred over 300, this is now outdated, this was 2015, there are now over 300 trials on metformin and cancer. Because what I've shown you for the moment is the connection. I haven't proven to you that if you take metformin, you're better off than if you're not taking metformin. And so within the next 2 to 3 years, we will start getting outcomes of these trials to actually prove that metformin is in fact protecting you against cancer or cancer mortality. So this is just a summary. There are various ways that metformin can work, which I won't go into, but there is a possibility that metformin may become useful as therapy in patients either preventing their cancer or preventing the aggressiveness of their cancer. And then finally, let me turn to the insulin therapy, because there was a scare after all our studies that in fact maybe insulin is making cancer worse in our diabetic patients. Remember that diabetic patients have a risk for developing cancer and that their mortality is worse. So why give them insulin if it could make it worse? And what I'm going to prove to you, I hope, is that it's not the insulin by injection. It's the insulin that we make that is what's bad for the patients. And when we give insulin, it doesn't make the situation any worse, and it turns out that insulin is safe to use in all of our patients. These were just some studies that came out in 2009, which worried people. There was a particular insulin that was widely used and still widely used today, but it turns out that the insulin that is injected gets converted to what's called an M1, a metabolite, and this metabolite is what the body sees and is entirely innocuous in terms of any growth of cancer. The best evidence is a controlled trial where you randomize patients to either getting the insulin or not getting the insulin. And what this trial showed, the Origin trial, is that there's no difference in patients taking insulin and those not taking insulin. There's no increased risk of cancer. And that's the best evidence. We try to take this a step further in our animal model to prove the point. And what we did is we got the company to give us this insulin. We got other companies to give us their insulins, and we injected into our mice. And what I'll show you here is that the insulin or the growth factors that make cancer grow are shown here. These insulins that we were studying that are given to patients do not enhance the cancer growth. So both in animal models and in patients, they seem to be perfectly safe. So let me finish just by saying, take-home message. Patients with obesity and diabetes have an increased risk of developing cancers and an increased risk of dying from the cancers. We should do everything to try and prevent this with lifestyle, exercise, and other options. But we, for the moment, have also focused on what are the causes of this, and we've come up with high insulin levels, endogenous, the patient's own insulin levels, the high cholesterol that the patients have, and we're looking for ways to intervene when this particular situation happens. Thank you. Toda rova.